talk right before this because this is the first time I've presented a case study, and so we're not going to have any statistics at all in here. If anything, the goal of this presentation for me was to present, for what I know for the first time at least in about 20 or 30 years, the notion of approaching non-traditional treatment goals in an alcohol use disorder setting. And so I'm actually almost as excited about the question and answer session part of this as I am about presenting my actual data. So just to clear up conflict and funding, this is data from an actual clinical case at our clinic. Alternatives Behavioral Health runs an intensive outpatient treatment center in the LA, Beverly Hills sort of area in California. So by virtue of that, there's zero blinding, there's zero assignment to treatment, right? This is self-selection at its best. A client came in, paid, specifically picked non-abstinence, moderate drinking as his treatment goal, and you'll see that we collect a lot of data on our clients. I'm an academic by nature, so they don't really love how much data I collect on them, but I think this is exactly the forum that it's really useful to do that in. So there's no outside funding. The beautiful thing about running research at our clinic is the clients pay for their own research, so I don't have to ask anybody any questions about what I can do and what I can't do. If it serves a purpose and I think that it's useful, I put an instrument in, so that gives me a little bit more leeway. I want to start out with just almost kind of what I feel like is an assertion, and I'm more than happy to open this up to conversation later, but I think in general, alcohol use disorder, I put the colloquial alcoholism in parentheses, has been considered a chronic disease for a while now, right? So since the mid-1800s when the term first came up, but even today, NIDA and IAAA, you look at what addiction is, and the chronic disease model is one. There's been a shift. This is no longer new. 3 years ago, if you talked about this, it was nice. Now everybody knows about it. DSM-5, continuum way of looking at this, right? So instead of yes or no alcohol dependent, we look at this thing as having a low, moderate, or severe level of alcohol use disorder. And yet, treatment primarily consists of these sort of acute, short-term periods of kind of monitored abstinence in the context, at least in the United States, and definitely in the LA area with our beautiful Malibu treatment world, but also in Florida, in this sort of 30-day residential treatment, sometimes not, followed by some more outpatient care. Really not exactly the sort of model you would typically use with a chronic disease in the treatment of that disease. And one of the other things that I'm going to try to kind of challenge here a little bit is that treatment success, and we heard in Dr. O'Connor's talk as well, is primarily measured by abstinence and consistent, consecutive days of abstinence. That's been the primary way that we assess whether somebody is successful at treatment. My little goal, and it really depends on what room I'm standing in when I say that, is that my perception of the shifts in the way that we perceive this suggests that we might want to start looking at other outcomes as the things that we care about. Because, well, actually, I think there are a couple of good reasons. First of all, we define the problem, and if you look at the DSM-5 or the DSM-4, quantity of drinking is nowhere in the definition of alcohol use disorder problems, and yet it's the sole determinant of resolution for most people. Is abstinence, so zero amount of drinking. And also the other suggestion that I make is if we're going to move to a place where we're going to start considering people as having low, moderate, or severe alcohol use disorder, maybe using the same techniques and the same treatment modalities and the same treatment approaches for all three of those levels. And I will argue, not in this talk, that we probably need more than 3 levels. But maybe they're not all the same. Maybe somebody who we consider a low alcohol use disorder patient does not need the same approach that a severe alcohol use disorder patients. So that's kind of the starting point, the philosophical starting point for this talk. And now we move to our case study. So I'm going to present the patient. We use initials for all of our clients, and it's a weird combination of names so that you can't figure out what it is. But we call him ALM. He came to us as a 29-year-old. He's now 30. He was unmarried, had a bachelor's degree, and was in film school at the time. He actually had to drop out of film school, you'll understand why in a second, to come to us. And actually, again, I'm going to give you a lot of sort of collateral information about this person because you're going to be hearing about him for a while. So he came to us. He was planning on going to treatment for a while, had had another residential treatment, episode that went okay in treatment, then relapsed right after treatment. But he was in film school and didn't want to come into treatment because he didn't want to disturb his film school career, so he was going to come after he had finished. But at intake, so he reported on this 30-day residential treatment, but was reporting that he was drinking heavily daily. So he was drinking about a pint to a pint and a half of vodka every day before coming to us. There was a little wrinkle in his plan in the sense that he wanted to finish school, but then ended up having to go to the hospital because he had acute pancreatitis and was not able to continue with his studies, and that rushed his beginning of treatment with us by about 2 months. He was hospitalized, which the beautiful thing about that means he also got detoxed in the hospital, so he did not need medically supervised detox by the time he came to us. And based on DSM-5, it was high moderate to low severe is kind of the thing. Again, I don't understand how continuums work with 3 data points, so I kind of use it as a more flowing way of looking at a continuum for alcohol use disorder. So he was in low severe sort of point is where you would normally diagnose him. What that looks like, you already mentioned the alcohol dependence scale, so I'm happy somebody alluded to it before I did. His score was 23, which puts him in the 3rd out of 4 categories. Recommendation there is either intensive outpatient or residential, depending on physiological symptoms. He had a Beck Depression Inventory score of 26, so moderate clinical depression. Anxiety was moderate, borderline problematic sort of, but definitely, again, clinically depressed. More than anything else, when I present this person, this guy's not a light drinker, right? He's not a problem drinker. I think most people, if he would have gone to any other treatment center, would have had a very clear sort of prognosis for him. I love that we have an international coalition here because I think that's not true for everybody. I mean, I think it's not true in Australia especially, but I don't know if that's because your beer cans are bigger or because you're more enlightened, but it's definitely one of the two. And in the United States, though, a person like this who'd required hospitalization, has been drinking heavily daily, et cetera, and all the things that I just given you, clinical depression, would have, without a doubt, in 99% of treatment facilities, been labeled an alcoholic or having alcohol dependence if they're still using DSM-4, et cetera, and would have been told that there's only one way for him out of this, and the way is to abstain from alcohol for the rest of his life. Now, the reason we even opened alternatives is because it is my firm belief that doing things like that keeps some people out of treatment because they hear that and they say, well, I'm not quite ready for that plan, so see you later. And he actually came to us specifically to approach moderation. So let's talk a little bit about what our treatment actually looked like, and then we'll present a lot of data. All of our clients start with what I now call our boot camp week, but that doesn't sound academic enough. So it's a 6 to 7 day partial hospitalization intensive course. Wasn't really difficult for him to engage in that because he just dropped out of school. So he had a lot of time on his hands, and he came in and spent these 6 days with us. Comprehensive assessment. So I'm going to present a small handful of the tools that we use, but we're talking about something like 30 to 40 self-report instruments, including a full ASI battery, a QEEG, quantitative encephalogram, brain scan that they do. They have multiple clinical impressions because they typically have a 4-person clinical team that they see during that week, so we all have a clinical case meeting about them afterwards, along with genetic testing, as already has been kind of talked about here. I'm much more limited because I'm not in an academic setting in terms of the specific kind of alleles that I get to test for, so we do what we can. The clinical treatment post, so the first 2 days they spend in this heavy-duty assessment period. After that, what I like to tell people is we're evidence-based in the sense that a lot of our CBT is sort of matrix model informed, if anybody knows that, mindfulness based on, not just sort of Buddhist meditation, but also mindfulness-based relapse prevention, stress response, some of the kind of classic things that you see. People typically ask us if you don't do AA, because we're not an AA-based treatment center, what do you do? And I say, well, all the other things that have been shown with data to be useful. We do all the other stuff. So along with that is a lot of psycho and neuroeducation, and then biofeedback in various forms. And for many of our clients, because we do have a lot of young adult clients, he's 29, so I think he's left the young adult world. But we do a lot of life coaching, structuring, things of that nature. It's important to note this is all outpatient. Even the PHP part of this thing, they stay with us for 6 to 7 hours, and then it's See you later. So they're able to drink throughout the entire course of the treatment. What we do is, at this point, they start an abstinence period, though, even if what they're looking for is moderation. So we ask for at least 30 days of abstinence, and I'll show you that this guy actually, on his own, decided to be abstinent for longer than 30 days, which I think is part of why he's so successful. Following this, and for those of you who work in the United States, you understand the insurance, maybe reimbursement part of this, and so that's why part of this is built in this way, is after that intensive week, they go through intensive outpatient. There's actually a clinically defined way to do that in the U.S. because of insurance reimbursement. So at least 3 days a week with at least 3 hours of clinical treatment in each one of those. You'll see that most of the stuff continues CBT and mindfulness groups and CBT mindfulness coaching individual sessions, and we do a good amount of exposure therapy with our clients around triggers. And then the biofeedback continues through this phase. By the time they move into the final stage, the outpatient phase, they're really coming in once or twice a week for 1 or 2 hours. So at this point, it's like seeing their own therapist. They go to a group or two, and they're done. And what's important in my next presentation, I still with the schedule shifting, I don't know if it's tomorrow or on the third day, but I guess we'll find out when they tell me I have to speak. We'll talk more about the monitoring that we do, because I think that's a huge component given the outpatient nature of what we do. But our clients carry mobile breathalyzers. You're going to see some of that data. They give us ongoing assessments of their mood, their stress levels, their anxiety, how well they slept, exercise, mindfulness, participation, all of those things. So they do that 3 to 4 times a day throughout the entire course of treatment. Okay, so pretty intensive level of treatment with what starts out as a pretty intensive drinker, right? And so let's kind of look. The first thing I want to show you is this. What happened with his drinking, right? Because in the end, even though we don't define the problem with level of drinking, I don't think a presentation like this would ever work if what I showed you is somebody who just drank the entire time they were in treatment and relapsed left and right and center, et cetera. So this client actually went with a 5-month period of abstinence. I don't think it's a coincidence why he's one of our more successful clients, but what ended up happening is he started right about now, actually it was September when he started, and so we were going to give him about 2 months of abstinence because he had a pretty rich history of problematic drinking, and then he realized that was coming up on the holidays. So it was around late November that he was supposed to start drinking again, and he actually came to us and he said, let's just hold off on this moderation thing, because if I start drinking now, then I've got Thanksgiving, I've got Christmas, I've got New Year's. I'm not really feeling like I want to test myself around that. Now, I don't know how many people here are involved in treatment at all, actual clinical treatment of people. Okay. I think the myth in our field is no client will ever say that to you. That as soon as you allow them to reintroduce drinking, they will jump. They will actually bring a beer to that session maybe, just so they can start drinking again. But we don't find that because drinking is not something we're going to tell them they can't do for the rest of their lives. Some of our clients extend, like I'd say about 20% of our clients end up extending their period of abstinence, sometimes because they're nervous about reintroduction, and others because they're actually making really logical decisions about when it would be a bad time to start drinking again. So what you'll notice is this. You see essentially no drinking all the way to the 5th month. This was about February when he started again. And then you'll see that, yes, this is maximum BAC. You'll see that his maximum BAC has, essentially, if you do a trend line, has consistently gone up. Part of that is by design in our program. When they start with us, they're only allowed to drink 1 drink a week. That doesn't give you a very high max BAC. Then they go up to 2 drinks a week. It's only in this phase right here that they're allowed to drink up to 3. So actually, this was him over drinking. Because on this one occasion, this only happened once this month, but on that one occasion, he had 3 to 4 drinks. He was only supposed to have 2 drinks. So this is actually, I'm showing you a client who has been very successful in moderation and yet slipped, essentially, based on the definitions of what it is that we were looking for him to do, but yet returned to a totally fine final months. So now we're talking about 5 additional months of moderation. What's important to me is if you look at this trend line, is average BAC, we're still talking about very small numbers. I think at the highest, only about 8% of his monthly readings show any level of alcohol. Again, going against the notion that if you allow alcoholics, in whatever form you want to call them, to start drinking again, they'll return to daily, near daily, ongoing, problematic binge drinking. We're not finding anything of that, and this is 5 months into measuring him in drinking. Okay, so hopefully I'm showing you somebody who's actually drinking and maybe once in a while drinking a little more than we would expect, but definitely not returning to anything near daily drinking, definitely not drinking 1.5 pints of vodka every day. He's nowhere near where he was before, and we're 5 months into this experiment, so we're feeling he's feeling pretty good about it, which is probably the more important part of the puzzle. Okay. But, like I said before, I actually don't believe that we should measure people's success only by their drinking. I think we should be looking at a lot of other things. So let's look at some of the things that have happened. And what I'm going to keep doing throughout this is actually separate it out into the abstinence and moderation phase, because let me ask the question to the room. What do you think the general consensus would happen to these people once you reintroduce alcohol into the picture? If we weren't given this presentation, what would people say? Damn it. Leave them. No. Right, okay. You think they'd be fine. Does anybody think that if you said this out there in the treatment industry in one way or another, yeah, that there would be a relapse, but not just drinking, because I'm having them drink. So I know that's going to happen for a fact, or otherwise they're really not cooperating with treatment. But a relapse in other senses, right? So their mood and their anxiety and their stress levels and their physical health, all that stuff's supposed to go down the window as well, right? Gave away the punchline. No. So here it is. So he started out not doing all that great. We saw significant, sorry about the contrast here, but significant levels of depression. I mean, this is clinical depression at onset. Also moderate levels of anxiety. And they're all doing what we always see they do during treatment. But then they keep doing that even once alcohol is reintroduced. So he's continuing to do better as he's doing more work with us and drinking. Now we're going to look at specifically at depression and blood alcohol concentration, because one of the things that when we start alternatives that I wanted to make sure would happen is that people could be doing poorly. They could go through, let's say, a depressive day, week, month, and not exacerbate their drinking, and vice versa. They could drink and not have that negatively impacting their mood. So we see that here, right? There's the peak right here, but no return in terms of his depression. Also no return in terms of anxiety. This guy's been reporting levels of anxiety. He started, you see, about the 23 mark here. About the 8 mark for anxiety is down to levels of 1 and sometimes nothing. His ADS score has gone down to 0 and has been consistently at 0 or 1 pretty much since the second month with us. I don't know how many people are familiar with the PANAS X. It's an instrument that measures emotional well-being across a whole slew of positive and negative emotions. So these are all the positive ones. You want these going up. They started out going up, and they continue going up through this moderation phase. Here are all the negative ones. You wanted these to go down, and they did go down and actually sort of plateaued right here. But again, like I said, absolutely no presentation of depression at this point for this client. So in my conclusions, like I said, I have no statistical analyses. I'll present some of that on the SoberLink and Breathalyzer tomorrow or the third day. But here is a presentation of at least one patient that showed continuous ongoing improvement across essentially everything that I measured. I would have shown you 15 more instruments if I had time, but across every instrument that we have, health functioning, general quality of life, etc., he's getting better. And that getting better, that improvement, was maintained and extended even into his reintroduction of drinking now for a period of 5 months. So really the point of me, the reason I even wanted to create this, the reason I wanted to submit it here, and the reason I wanted to present it was I think it's time for us to start throwing out the window a little bit the notion that the only way for somebody with drinking problems to get better is for them to stop drinking. Again, we do this with a period of abstinence to start out, and I think there are a multitude of reasons to do that. I can tell you that I know of stories from clients of ours that did not have an initial period of abstinence and are still doing much, much better later on with lower levels of drinking. I really want to start introducing this notion that as we move to a more kind of continuum way of looking at alcohol use disorders and probably one day drug use disorders, this sort of abstinence as the golden standard of success is something we are probably going to need to get rid of, because it's probably, to me, as damaging as many, many other things that we do in the treatment world for alcohol use disorders. Thanks.